Hello everyone. Next, let's talk something about the diagnosis of pulmonary thromboembolism. Well, it's very difficult to diagnose pulmonary thromboembolism actually because this disease, it has non-specific symptoms and signs. Mostly patients just have unexplained breathlessness, and we do have coexistence of PE, which is also called occult PE, that can exist with other disease, which makes the diagnosis of pulmonary thromboembolism even more difficult. And this study compared two groups of patients. One group is PE, confirmed PE. One group is not confirmed PE. You can see here, these two groups of patients, they share almost the same symptoms. They all have dyspnea, they all have pleuritic chest pain, they all have cough, they all have substernal chest pain, fever, hemoptysis, syncope, almost the same. So it's really difficult to differentiate and really difficult to do the diagnosis simply based on symptoms and signs. And about DVT, most common symptoms for DVT is cramp or charley horse in the lower calf. And most patients have palpation discomfort. Thigh swelling and tenderness and erythema are also quite common. And for the differential diagnosis of DVT include ruptured Baker cyst, cellulitis, post-phlebitic syndrome, or venous insufficiency. And for the differential diagnosis of PE, we have pneumonia, asthma, COPD, congestive heart failure, pericarditis, pleurisy, rib fracture, pneumothorax, acute coronary syndrome, and anxiety even. And since it's so difficult to do the diagnosis of pulmonary thromboembolism, we do have some Punnett score criteria to help us to do the diagnosis. Here is a typical clinical decision rule for us to do the diagnosis of DVT and PE. We're not going to go through all the items here. And we also have Wells rule and also revised Geneva score to help us to diagnose pulmonary thromboembolism. Actually, we have two versions of Wells score and revised Geneva score. One is original version and one is simplified version. Both versions have been validated by so many studies. And D-dimer is the most common lab tests that we use to help develop diagnosing pulmonary thromboembolism and DVT. But actually, the negative predictive value of D-dimer is quite high, and the positive predictive value of elevated D-dimer is quite low, which means a normal D-dimer level renders acute pulmonary thromboembolism and DVT very unlikely. Well, a positive D-dimer testing is not that useful for the confirmation of pulmonary thromboembolism. We have other non-imaging diagnostic modalities like elevated cardiac biomarkers, troponin, BNP, NT-proBNP. They all help us to identify right ventricle overload. And we can also use EKG to help us do the diagnosis. Usually on EKG we can find sinus tachycardia, T-wave inversion in leads V1 to V4, and a special type of appearance on EKG that is S1Q3T3. So S wave in lead 1 and a Q wave in lead 3, and an inverted T wave in lead 3. This is at 1 Q3 T3. Other non-invasive imaging modalities include chest X-ray, CT, CT angiography, and lung scanning, MRI, echocardiography, and venous ultrasonography. For chest X-ray, usually patients with PE, they have normal or nearly normal chest X-ray, but some several signs can be seen in some of them. For example, Westermarck's sign, which indicate focal oligemia, and Hampton's hump, which is actually a peripheral wedge-shaped density above the diaphragm, and Pallas sign, which actually suggests an enlarged right descending pulmonary artery. Here is Westermarck's sign. Here you can see oligemia of the right lower lobe on this chest X-ray, indicate a lack of vascular marking distal to the pulmonary embolic obstruction. And this is a small one, a small oligemia on the right upper lobe. And also you can see on the CT scan, we can clearly see the thrombus. And for chest X-ray or CT angiography, it is actually the principal imaging test for PE. Usually we can see the filling defect in pulmonary artery or its branches. And we can also use CT to do the diagnosis of pelvic and proximal leg DVT. And CT can also help us do the differential diagnosis of pulmonary thromboembolism. Here's the typical CT appearance of pulmonary thromboembolism. You can see the filling defects on both sides of a pulmonary artery. And lung scanning is a second-line diagnostic test for PE, especially useful for those cannot tolerate intravenous contrast of CT. We use small particulate aggregates of albumin labeled with gamma-emitting radionuclide, that is technetium, to do the perfusion scan. And we use radio-labeled inhaled gas, xenon or krypton, to do the ventilation scan. Usually for PE, if it's a high probability scan, usually have 2 or even more segmental perfusion defects in the presence of a normal ventilation. Actually, we have 3 types of results for this lung scanning or VQ scan, and that is high probability, normal, near normal, and non-diagnostic scan. Here is two results of lung scan. On the left side is normal perfusion scan and a normal ventilation scan of the same patient, while on the right side is normal perfusion scan and very obviously perfusion defect. MRI can also help us to do the diagnosis of pulmonary thromboembolism and DVT. It can be used with gadolinium contrast for DVT, and also we can use MR pulmonary angiography for the large proximal PE. But the sensitivity and it's not that good for MRI. Echocardiography, it's useful for the differential diagnosis of right ventricle overload. And sometimes it can help to find the saddle pulmonary thromboembolism or right main or left main pulmonary thromboembolism. McConnell sign sometimes can be seen in patients with right ventricle overload. We can see hyperkinesis of the right ventricle free wall with normal or hyperkinetic motion of the right ventricle apex. Right ventricle stretch can also be seen on echocardiography. Transesophageal echocardiography can also help us to do the diagnosis and differential diagnosis. Venous ultrasonography is the first line imaging modality for the diagnosis of DVT. In those patients with DVT, we can see loss of venous compressibility, and sometimes we can even visualize thrombus, which looks like homogeneous with low echogenicity. And we can also see mildly dilated vein, or we can see venous flow dynamics. On venous flow dynamic, we can see low venous flow or even absent venous flow. Here's typical pictures of echocardiography for DVT. Well, for invasive diagnostic modality, we have pulmonary angiography. Actually, it is the gold standard for the diagnosis of pulmonary thromboembolism. On this pulmonary angiography, we may find intraluminal filling defect in more than one projection, and we can also find abrupt occlusion of vessels, segmental oligemia, or avascularity. Sometimes we may find a prolonged arterial phase with slow filling, and tortuous or tapering peripheral vessels. And this flow chart may help us to prescribe diagnostic modalities. First, we need to evaluate this patient. If the patient is not that severe, this suspected PE patient don't have shock or hypertension, then we can do the clinical judge, or we can use those prediction rules to help us to assess the clinical probability of PE. If the probability is very low or moderate, then we can do the D-dimer test. If the D-dimer test result is negative, it's safe to rule out pulmonary thromboembolism. If the D-dimer is positive, then we need to do the CT angiography to confirm the diagnosis. If the patient's clinical probability is very high, we don't need to do D-dimer, or we don't need to wait for D-dimer test's result. We can do CT angiography directly to confirm the diagnosis. While if the patient have shock or hypertension, which means the patient have a high risk of death, we do the CT angiography directly to confirm the diagnosis. But sometimes the patient is so severe, you can't even move them. You can't take the patient out to do the CT angiography. At a time like this, we can do the echocardiography. It is a point of care examination. We can do while patient is in bed. We test patient. We examine patient to find if the patient have right ventricle overload. If the patient don't have right ventricle overload, then we need to search for other causes of hemodynamic instability. If the answer is yes, we can, and no other tests. No other tests. It's for the patients, or this patient is unstable, then we can treat this patient directly. If the patient is stable now, we can do the CT angiography to confirm the diagnosis. After the diagnosis, we need to stratify this patient. If the patients have shock or hypertension, then we classify this patient as a high-risk patient. If not, then we classify this patient as non-high-risk patient. For those non-high-risk patients, we can do the that is pulmonary embolism severity index, and also we can use echocardiography, and also we can do the lab tests for cardiac biomarkers to further stratify these patients as intermediate high risk patients or intermediate low risk patients or low risk patients. Okay, that's all for the diagnosis and the stratification of pulmonary thromboembolism. Thank you.